just give an illustration of how the Kenya HMIS developed ML model works, with a few illustrations with the decision trees and some other screenshots of what's behind the hood. And then we'll then take a look at the ML for IIT risk categorization. And then in the last phase, we'll usher in Frida to do demonstration of those two features. So I would like to just go straight into it. I wanted to just get us up.
Sorry, Ajwang, your screen is kind of frozen. Would you like to maybe unshare then reshare? And also have it on presentation mode.
Okay, I'm just back there, just 1 moment. You can see my screen?
Yes, yes.
All right. So in terms of definition, machine learning is about teaching computers to learn from data using certain algorithms, most of which are based on statistical methods, so that the machine can find patterns and any correlations in that data set. And eventually we aim to make decisions or a prediction out of that. So that definition in a way encapsulates all the key elements of machine learning. That is the use of algorithms and analysis using large data sets so that we ultimately find a prediction or a decision from that data set. So in terms of algorithms, there are certain common algorithms that are used to help the machines make those decisions. The simplest one is the one for linear regression, where you have a simple correlation between two properties, and then going on to complicated ones like logistic regression for statisticians, naive Bayes, random forest, XGBoost, among others. So that is our definition for our working definition for now. So we just want to look at the machine learning process. Just to be clear, it involves us collecting data and inputting and preparing that data to be input into the ML model that will have been developed by the data scientists. That model is then trained with the data collected to give us tests or results. Those results are then analyzed, and once we are satisfied that the prediction or the decisions being made are good enough, then we take that model out for deployment. If we feel that the results are not good enough, then we are allowed to retrain again. That would perhaps mean collecting new data sets or just adding a little more data into what we currently have. So that is, in a nutshell, what the process involves. And that is a process that we actually followed in developing the two models by Kenya HMIS project. So I wanted to share a simpler illustration of machine learning in everyday life. So even before it was called machine learning, there used to be a number of algorithms that people would use to predict certain quantities. So in this case, we have a linear regression being used to define for us, to estimate for us what, for example, would be the salary for someone who has worked at a company for 9 years. So we all know typically salary paid is based on how long you've worked And so it follows that the more experience or the longer the years, and the more salary you get. So in this example, if you can draw that particular straight line with the correct gradient, then you'll be able to actually estimate that someone who's worked at this factory or company for 9 years would be drawing, say, 110,000 based on the current trends. And I believe that is as simple as as you can estimate. Okay, so in our case, we wanted to apply machine learning in HTS screening, and some of the problems that we wish to solve were as follows. We wanted to be able to target HIV testing by identifying eligible and high-risk clients over low-risk clients at the facility level. We also noted that there is a tendency by the manual eligibility screening to screen out ineligible clients from HIV testing. And we wanted to kind of introduce some form of objectivity into the screening process so that it would not be so much based on each provider's intuition and decision making. We also noted that there was a problem that the manual screening process was, as it was then, that was before last year, was mostly non-standard, and each program or each project kind of had defined its own eligibility screening algorithm. So that kind of drove our need to want to standardize and to want to augment the decision making by the HTS providers in terms of screening people who would be eligible for testing. So in terms of rationale, this algorithm leverages on patterns that exist in the data to predict patients who are likely to be HIV positive. It can assist providers to identify and screen in high-risk patients for HTS, as we are going to see in the next slide. And also ML can help standardize the screening and automate HIV risk certification, as we've seen to be the problem up above. So those are the problems that we faced and the reasons why we sought to adopt ML in HTS screening. So in reviewing the HTS screening algorithm at the facilities, to support ML screening as well, we came up with this particular phased approach. So in this case, the client would present themselves at the OPD, MCH, or VCT service point, and then we would then screen them using the standard tools. In our case, the idea was for us to note as you are screening, just to document the salient or the relevant details of the client into the system, and then have the machine help you decide whether this person is eligible or not eligible. So at that point in time, we do not actually interfere with the decision making by the provider, but we allow them to use their own judgment and also use the prediction from the machine to help make that decision. At which point, if you're eligible, you'll proceed for testing, and thereafter the test results would either be positive or negative, or in some cases inconclusive, in which case you'd be referred back to do a repeat test. So this is the algorithm that used to work manually, and in a way we sought to add the ML in this same process. Okay. So how does the ML model help improve eligibility screening? If you look at this diagram over here, we know that if you do screening manually, there are certain questions to which you would typically, if you find the same answers or the same assessment, you would always classify certain clients to be not eligible. Okay, so it is that kind of setting where we thought to, in number 2, have ML assist with that risk assessment. So the ML is able to tease out other patterns on the client profile other than some of the common assessment indicators, big indicators that we always look out for as healthcare workers or an HTS program. So in that case, we realize that HTS can then, the ML model can actually then help us screen in more patients who are high risk, who probably would have been left out if we only used manual process. So in the next, on this slide over here now, I wanted to just illustrate when we compare the manual HTS screening algorithm and the ML model, which already has behavioral variables, what's the difference? So typically from the manual algorithm, with this kind of profile of Jane as a single female, age 22, who is from the general population, who last tested 12 months previously, coming to the hospital and has not self-tested and has no presumed TB. In our assessment, in most cases, most cases, the manual algorithm will classify this particular client as a low risk, and in that case, just send them away. So when we augment the provider's assessment with the ML model, which currently has now included behavioral variables in addition to the regular HTS variables, we are able to tease out that one, Jen is a sexually active client. Jen came for testing on a Monday at the facility. Her entry point was the OPD, and she's not in a long-term union. And Jen is also not a health worker. All those 5 points, these particular 5 points are those that typically we would not be asking for or we would not be teasing in the manual algorithm. But when we apply the ML model, these particular features or information about Jane actually help to elevate her risk profile to high risk. And in looking at this particular case, this was an actual case that was teased from the data set. Jane actually tested positive, and we confirmed that using the manual HTS algorithm, this would not have been possible, as the guidance would suggest not to test her. So this is, again, a demonstration of how we can leverage on the ML to actually help guide on testing and screening clients. So next, I would like us to just take a look at what actually happens with the ML model that we are currently deploying. So this is an illustration of decision trees. And decision trees typically work in a point of you give a number of variables and you develop one tree, develop a second tree, and so on and so forth. Like in our case, the model runs hundreds of trees, which we feel would not be very possible or would not be practical for, say, a human being to accurately use to predict. So looking at table 1, looking at tree 1, starting with a testing strategy as index. So in this case, testing strategy index is one of those highest yielding strategies. So in this case, the client presented to test as an index client, and the client's HIV partner HIV status is unknown, and also the month since the client tested is more than 12 months, and then the machine would then predict that as a high risk. So what happens with the model is typically it doesn't end there, because there are a few more trees. There are a few more trees that can then keep on running. So in the next tree, for example, then the variable or the feature of age is then elevated as the first one. And when it's elevated as the first one, in this case, I'll follow this. Age 18 years or above. This particular client is not over 18, but is presumed to have TB. Marital status is divorced, in which case then the system will then predict her to be medium risk. So I know probably you would say if they are not over 18, then there is no way they would be divorced. But again, this is just an illustration of how that works. So the regression then works by taking one key variable at the top and then going all the way down to the lowest level, building the trees all the way to the lowest level, and then takes the next one and so on and so forth. In that way, it's able to run and get a better prediction than what you could possibly assume or presume from looking at simple data. So in terms of performance of the HTS ML model, this is what we currently have. And I think for those who know a little bit about the model performance, you will understand this. So the recall factor here, first of all, the model places all the clients into different categories. We've got the low risk, we've got medium risk, high risk, and highest risk. So if you use this feature in the EMR, you'll have noticed that there are certain clients who get to be classified as highest and others as low risk. Typically, it's recommended that you test the highest risk, high risk, and probably medium risk if you're convinced as a provider that that client needs to be tested. We don't recommend testing of low risk. So if on the sample that was used for these results, you can tell that our model classified 1478 clients as highest risk, all the way down to low risk of 6,260. And that recall factor up there simply indicates how well the model was able to bin or to categorize, to place people in the correct category. So what this shows, for example, is we have 100% recall, which means everyone who was placed as a low risk was a true low risk, in which case, if it's recommended, do not test, you do not need to bother with the testing. So that goes, it drops down all the way to highest risk. But for the highest risk, again, you can tell the positivity rate for the highest risk in this data set. We had 348 compared to 174 for the high risk, dropping down to 140 for medium risk, and then a low of 34 for the low risk. And in terms of sensitivity, you can tell again that our yield from this particular set of data is for the people classified as highest risk, we are getting prevalence rate of 23.5. High risk has a prevalence rate of 5.8, medium at 1.4, all the way down to low risk of 0.5. And this compares very favorably to the national prevalence rates of 3.3 or to 3.8 thereabouts. In this particular data set, the prevalence rate that was discovered was at 3.3. So if that is the average, you can tell that the people being classified as highest risk are actually given much more prominence. So that is the data, and that is the model speaking. We believe those results are way better and can actually assist with the program decision making and service provision at the facility level. So in the last slide for HTS here, we're just looking at typically what that form looks like. Currently, this form is available from the HTS initial form. And once you've completed and updated this set of variables, you are allowed to get the risk category, and the system would respond by giving you a classification here of the category to which this particular client belongs. And then next to it, there is an advisory, which we will see more of in the demo that comes. So the second the second application for ML for us has been in IIT. This is one that I believe most of us or all of us would be familiar with because it shipped with Kenya EMR from day one. And the problem that we tried to sort out here was to get the patient outcomes to be able to get the patient outcomes and flag them before the patients actually interrupt treatment. So this has been a problem because primarily we talk of IIT once it has happened, and the program wanted a way if you can flag potential IITs and let the program team make necessary arrangements to get them to continue treatment. The rationale again is that the ML algorithms are capable of leveraging patterns in the existing client profiles so that they can flag those people out for us. And in so doing, we would then be able to assist providers identify and mitigate potential interruption earlier on before it occurs. And that means that we can then enable or empower the service provider to be more proactive and targeted in their actions to prevent IIT for people who are at risk. So this is a simple illustration of what the IIT looks like. There's going to be a much more expansive demonstration of IIT for this purpose. There's just one thing I wanted to just re-emphasize that in most instances, as a provider or as a practitioner, you'd want to know what is the biggest predictor for any of these cases. And the reason why we feel that ML is a good tool is that it can actually go counter to what we typically know about, say, IIT, for example. I remember last week we had a very interesting statement that from the data, the biggest predictor of future IIT is what? Is actually past IIT. And the model actually shows this clearly. Whereas sometimes you would think someone missing appointment will be a predictor. It is not. And I think the data actually shows this. So with that, I would like to turn it over back to Otieno and to the next presenter. Thank you, Otieno.
Yeah, thank you, Ajong, for that. Yeah, so I think without wasting time, I don't think we need to open it up for any question right now. So let's just get right into the demonstration by Frida. Then after that, we can now open it up for questions. But should you have any question right now, I would really urge you to just type it in the chat area so that we can be able to respond to it. So welcome, Frida. Please take us through the next stage.
Thank you, Tenu, and good afternoon, everyone. So I'm going to demonstrate how ML works at the facility level. So we are going to be able to see the ML for HTS as well as ML for IIT. So for starters, we're going to look at ML for HTS. So basically, we have the feature in one of the HTS forms. So for you to be able to get the predictions or probability that the client you are working with is going to test positive or not, or you can go ahead and test them, you'll first need to register your client as always. So I have a client who I've already registered them. So then again, as always, you just need to check in your client to be able to access the HTS form. So first things first, you'll be able to fill the HTS eligibility screening form. So I'm just going to fill this very fast. So this is what we normally do at the facility level. So you'll just complete the eligibility screening form. So assuming the client I'm working with is non-hospital patient who is not a healthcare worker, and they don't have any relationship with an index client. And assuming this client has never been tested for HIV before. So the moment I say no, of course, the client is eligible for testing. If I say yes, then I'll be required to put in more details, like who performed the HTS test and the results at that time, and maybe the date the test was done, assuming the test was done much earlier this year. Then the risk assessment behaviors. So has the client ever had sex? You'll be able to specify, assuming my client has ever had sex. So if they've ever had sex, are they currently sexually active? Assuming yes, has the client had a new sexual partner in the last 3 months? Assuming yes, partner HIV status, assuming it's unknown, then whether the couple is discordant or not, assuming it's no, then let me just put no for the remaining questions. Okay, so has the client recently experienced GBV? Let me just say no. Has the client received any of the following services recently? So if the client had been on PrEP for some time, you'll be able to indicate appropriately. And then whether they are currently on PrEP, again, you'll be able to say yes or no, assuming it's no. And then scrolling down, now we have the eligible for testing. Now, this form is very key in helping the model that we are using to be able to predict for us whether this client is at a high risk of turning negative or positive. So we are urging facilities to kindly complete this form, collect as much information as you possibly can, even for those fields that are not really mandatory. So once you've filled up to that point, then the last bit is whether the client, any traditional procedures done. So assuming it's no, then the client is eligible for testing or not. So I'll say the client is eligible for testing, then client has been deferred for testing. Then you enter form. So once you've entered form, the next form that is supposed to be filled is the HTS initial form. So I'm going to adjust the date to reflect the date that the client came to the facility. So that is November 1st. So the client is the general population. I'm going to say the client has no disability. The client has been tested before, as we had said in the eligibility screening form. So I'm going to say it's been 6 months. Then the client has never done any self-test. HTS setting, assuming this is being done at the facility level, and this is being done by the provider, the one that initiated the testing. Then the strategy used, integrated VCT center, TB screening results, assuming the client has assumed TB, then the client has consented to be tested. The moment I say consented to be tested, you're able to see get risk category. Okay. Then I say the client is being tested as individual. Then I click on get risk category. Now, that highest risk client, the reason why we're able to see highest risk is because of the information we fill from the eligibility screening form, plus part of the information that we've been able to capture from the HTS initial form. So all those variables combined, the model is able to tell us whether this client is at a high risk of turning positive or not. From what you can see from my screen, you are able to see the client as a highest risk client. So this client, these are too small right in there. This client has a very high probability of a HIV positive test result, and you're being recommended to test the client. Okay. So from here, you can now proceed to test the client the normal way. Okay. Put the expiry date, assuming that from the test the client turns positive, and then you do another test with first response. And test is also positive. Then the final result is positive, and the result has been given to the client. Now, if assuming you'd have, after you click on get risk category, and the whatever you're seeing there as the probability being projected with the client is a low risk client, then this is supposed to also help guide you also from the way you'll, as a caregiver, you'd have assessed the client, whether you think that you should proceed to test the client or whether you think there's no need of proceeding to test the client. As you know, currently there is shortage of testing kit. So the ML for HTS is also coming in handy to be able to help you know exactly which category of population, if you test, will give high yield as compared to just testing anyone. And then at the end of the day, you get low yield from a population that were not even having a high probability of turning positive. So it's very important for us to be able to use this to be able to guide us when you're doing testing for our clients at the facility level. So scrolling down, the rest of the steps are just the normal steps that we normally do. So after one has been tested and they turn positive from the initial testing, then they're supposed to be referred for confirmatory testing. Then you'll be able to indicate whether it's being done at this facility or they prefer it to be done in another facility. So I'll say this facility. Then if there are any remarks that the clinician feels they need to document, they'll be able to document under the remarks field. Then you enter form. Okay. So basically that is it for the ML for HTS feature in the EMR. So Otieno, I don't know if I should proceed to the IIT, or we can have questions if at all there is.
Yes, thank you, Frida, for that. Yeah, so guys, we have looked at the first application for ML in the HTS use case. Should you have any question, I think we can just maybe pause for 5 minutes to get those questions around the application of ML in the HTS screening. If you have any question, kindly just raise up your hand. I'll give you a mic.
So maybe just a comment as we elicit for questions. So the same thing applies in the HTS retest form. You'll also be able to see the risk scores for the prediction scores for the client once they reach the CCC when they're being retested again. Once you fill the form, then you'll be able to see whether the client is still at high risk or not. So the same also is there in the HTS retest form.
Okay, so we can just pause for a few minutes to get your questions or comment should you have. Yes, Elizabeth, please unmute and ask the question. Elizabeth, kindly unmute and proceed.
Good afternoon.
Good afternoon.
I'm logged in with the Machakos Level 5 team, and I'll give James to ask the question.
Okay, I have a question. Since that you have to key in the eligibility screening form, so that we can get the high risk. I'm asking for the old clients. What are we going to do to get the IIT?
For which clans?
The old clients already in the CCC.
So this is supposed to help you make predictions before you test the clans. Okay, so for the clans who are already tested, who have already been entered into the EMR, there's nothing much you can do with this feature right now, but it's supposed to help you make a decision moving forward.
For the new clients,
Yes.
If I can add.
So for the old clients, there is nothing we're going to do about it. So we'll just need to use this for the new clients only.
So if I may ask your definition for the old client, what do you mean by the old client?
So the
Bernard, maybe I can make a clarification.
Okay, Doc.
So the model that has been presented by Frida is specifically for HIV testing. So this is applicable when you're screening a client to help you make a decision whether to test for HIV or not test for HIV. So if you saw what was presented by Ajwang, you'll have seen that there are similar questions that like the ones that we do before you screen a patient for testing. And this helps you know the risk category of the patient and recommend testing or not testing based on the risk profiles that are provided there. Now, for the older patients that already enrolled in the CCC, we'll have a use case for their machine learning, and this is about predicting their risk of interruption in treatment, and that will be shown shortly after this. Thank you.
Thank you, Dr. Mudoka, for that clarity. I think that has been very clear. Should you have more questions, please just raise up your hand and ask. So let me give the mic to George Utino. Kindly unmute and proceed.
Okay, thank you. I don't know whether I'm audible.
Yes, you are.
Okay, thank you. So that's a wonderful presentation, and it's quite useful, especially when resources are dwindling or they are becoming less and less available. So my question is on the small percent of the small proportion of clients who test positive or who would be positive, but the ML doesn't pick them up because of the responses during the screening. How would we pick that? Maybe in the future, if you have thoughts about how to be able to capture them, maybe in the future, and how to modify or incorporate those characteristics that may not have been picked by the machine learning, probably in the future. Thank you.
Thank you for that, George. Dr. Mudok, I don't know if you want to respond to George.
Yes, I can. So I think we majority of us are familiar with the concept of sensitivity and specificity and the trend of thereof that sometimes you have to make when you're making some of these decisions on whether to test or not to test, similar to almost all diagnostic tests. And I know the program and everyone in the country would want a case where we're able to have 100% recall, meaning that we identify everyone who is at risk. It may be a bit difficult to do this in practice, but what I would want to encourage the team is the machine learns based on the data that is available. So with more continuous application of the model, And with people collecting more data, the precision and the accuracy of the machine to be able to, of the model to be able to pick those who are likely to be positive will increase over time. So my encouragement to the team is to roll out. More data will become available. Then we can see what type of results we can be able to get over time. The alternative is, the manual eligibility screening that we have that we know has some gaps and are missing a little more people. And the other alternative is testing everyone, and we know this is not feasible. As you approach epidemic control, we know identifying the remaining few becomes a bit more difficult. Thank you, Bernard. And George, that's a good question.
Yeah, I'm grateful. Thank you.
Thank you, Doc, and thank you, George, for that question. I'm looking around if there are any further questions. Okay, I think the only question I can see in the chat area is from Tumutumu Hospital. From Zau Abednego asking what is ML, and I think you've already been responded to by someone from Tumutumu Hospital. So thanks for that. So if there are no further questions, then I think we can proceed to the next application of the ML, of the machine learning. Now, as has been explained by Dr. Muthoka, we are going to look at application of machine learning in detection and prediction of patients that are likely to interrupt their care. So at this point, I think we could just proceed. Frida, kindly continue.
Thanks, Atieno. So for ML, for IIT, for prediction, so people who are likely to interrupt treatment. So the algorithm that is in use is executed on the National Data Warehouse data, and then the results are then pulled from the National Data Warehouse data to the facility EMR instance. So for you to be able to get those risk scores, the first thing you need to do is to click home. Let me just close this patient. Okay, then I know most of us have been able to see this machine learning module in their local instances in the EMR. So we need to be able to pull those risk scores from the National Data Warehouse. So we click on the machine learning module. So once you've clicked on the machine learning module, then there's this synchronized data under the data management actions. So you'll click on synchronized data. So if you're doing this for the first time, then you will see an empty ML summary, okay? So, but if it's not for the first time, like you can see from my screen that I already did this, I already pulled some risk scores, so you can see some risk scores. So if you want to be able to get the latest predictions, of course, you have to be able to pull this. And pulling the risk score, you're advised to do it once every single month so that you are able to pull the latest risk score. So the first thing you'll do is to change risk score again. So that is where you are able to see a summary of what you should be expecting from your report. So once you've pulled, then you'll be able to see your total patients who are likely to be on IIT. You'll be able to see those who are at high risk of being IIT, those who are at medium risk of being IIT, and those who are at low risk of being IIT. So the moment you pull the scores, again, as I've mentioned, it fetches the current information to your local instance. So once you've done that, then you navigate back to home. For IIT, we don't really have a feature in any of the forms, but we have a report. So you simply click on the report module. Then we have the IIT. IIT report. So also just to comment on this before I even generate the report. So when I pulled the risk scores, you are able to see high risk, medium, and low risk. Now, the report that we have is only on the IIT high risk because we figured out that availing medium and low risk may not really be of much help, especially when you want to follow up with this patient and just do targeted actions to be able to ensure that they don't end up being IIT maybe in the next few months. So what we have is on high risk, report on high risk and not on medium or low. So when you generate this report, you'll be able to see the clans that you are able to see when you pull the risk scores from the ML module. Now from the ML module, if you are keen enough, you realize that we had 0 high risk. So that means even the report that you're looking at is going to be 0 because we don't really have any client from the data that we are working with, which is the test data, who has a high risk. So again, this is just a request to the people on this call. If you can, after this session, you can just go back to your facility if you're using the latest version of the EMR and just try to pull your risk scores at the facility level and then just check from the report your high risk clients. So for now, even if I generate it, it's going to be 0. I think I already did. So if you view, you see that we have a total of 0. So you'll be able to generate. The report shows as any other line list that we normally have in the EMR. So you'll be able to see the list of those patients who are at high risk of being IIT. Then now you can follow up with the individual patients. You can just follow up with them and just ensure that they don't end up being IIT in the near future. That is from the report level. Again, you can be able to click on a specific patient, as I've mentioned, and just be able to follow up with them when they come for their drugs, maybe for the next appointment. Again, you can also be able to just see the risk scores for this client over time. So if you want to see how this patient has been at risk of being IIT over a long period of time, especially those patients who are already marked, those you would have gotten from the IIT report, high risk report, then you simply come to machine learning, the module again, and then you're going to be able to search for the client you want. Another disclaimer, because I don't have any client who is on high risk, will not be able to practically see this, but you can just search for the client, and this will be very much possible from the facility level. Search for the client the normal way. Once you click on the client, then there is this IIT risk score. You'll be able to see a graph of how they've been at risk for the past 6 months. Okay, so you can be able to tell at what point they were at the highest risk, at what point, like the risk score levels for this specific client over the period of 6 months. Something else, we have notifications, alerts, clients who are at high risk of IIT. Again, I had 0 high risk clients. So assuming this client that I'm showing is deceased. Okay, let me just go back. Search for a different client. Give me a second. Okay. Yeah, so I've explained about the IIT risk score for the individual patient. Again, you'll be able to see an alert here, like the rest of the alert, telling you that this client is at IIT, is a IIT high risk client. Then we also have the IIT risk scores. So you can be able to view the risk scores here, or the moment you open the patient information from the clinician or even the registration module, then you can be able to see the risk score. So if at all they are at 60% or 70%, whatever IIT risk score that they have, you'll be able to see that. the evaluation date, a brief description, and the factors or the variables contributing to them being at risk. Okay, so you'll be able to see all that listed here. Unfortunately, I couldn't be able to show this, but this is something that you'll be able to see when you go back to the facility and you actually synchronize the data, pull the risk scores, and just check from the facilities listed on the report. So that is basically it from the demonstration. Back to you, Chen.
Thank you very much, Frida, for that. And I hope maybe that has also been a good eye opener for the guys. Maybe have been seeing that feature. They have been seeing that section of IIT risk score, and they've been wondering what is this all about. So I think we've learned and we've seen something new. I can see a hand from Elizabeth. Kindly just unmute and proceed with the question.
Oh, this is Catherine, HRIO Machakos level 5. It's actually a comment. We've tried pulling the IIT data and it's working. So we just wanted to verify that. Thank you.
That's very good. Thanks for that positive comment. I think we are glad to hear that it has been working for you. Thanks, Machakos. Any other comment or question? Can't see any more hands. Maybe as you think about what to say, I've seen a question in the chat area asking what version you should be in for you to get the machine learning feature. Yeah, so I think the machine learning feature for HTS has been around for a very long time, from 18.1. I think before we started doing the NUPI verification. So if you have ever done NUPI verification successfully, then know that you've been having that feature in your instance of Kenya EMR. And I think today provides a very good day just to sensitize you that you have that feature. You can put it into use right away from this particular training. And also that goes for the machine learning for the IIT. If you are on version 18.2 anything, 18.2.x, you have it already. So just look at that feature and see how, if you can be able to pull the reports like it has been shared by the Machakos team, and then let it help you make some decisions on the patient well-being in terms of preventing the unlikely outcomes of undesired outcomes of interruption in treatment. Okay. Again, also, I think this one, just to put it out there, I think last time I was having some discussion with a certain facility about the IIT. There was a confusion between IIT prediction and the missed appointment or lost to follow up. So I think I just want to put it out there that they are different. Whereas the lost to follow-ups are incidences that have already happened. They are interruptions that have already happened. Somebody has already been declared as lost to follow-up or missed appointment. There is no prediction about that. But this particular technology is helping you to predict the future about a patient that may seem to be keeping all their encounters, all their appointments, but the prediction tells you that whereas this patient is keeping all the appointment, there are chances that they may fall into interruption in treatment in the near future. So as a facility, you can take that time to really intervene and see how you can reinforce this patient so that they don't fall into that they don't have to interrupt their treatment in that future. So the two are different, but I just felt it was good to have that out there so that we don't confuse it. Yes, so I don't know if there's any other question or a comment. I'm looking at the chat area. I cannot see any comment. Let me just scroll up. Yeah, and again, if you need more resources, more materials on machine learning, Kennedy Ugutu has posted various links in the chat area. You can visit those links so that you can get resources in terms of how to use the features. That also goes for the service desk toll-free line. Should you want to contact the service desk or ask further questions, then the toll-free number is issued there. Feel free to just call in and then you'll be assisted. Okay, so I don't know if I'm locking anyone out. Duncan Hongo is asking, how does the system automate the IIT? What factors is it looking at to predict an IIT? Yeah, I think that's a very interesting question that I would like to pass to Dr. Mudhoka. If you could just help Duncan understand how that automation comes about, what are some of the factors that the model is looking at to come up with that prediction?
Thank you, Otieno and Duncan for the question. So for model prediction for IIT, we did a literature search on what factors contribute to interruption in treatment. Then in the National Data Warehouse, we looked at the available data and the completeness and utility of such data. I'm sure you heard when Ajwang was presenting, he talked about history of IIT or missed appointments, which was one of the factors that we looked at. So there's a long list of predictors, the routine predictors that we use to be able to predict whether one is likely to become IIT or not. It's a comprehensive list and showing some results, and we have a presentation that is tailored towards this discussion. I know the scope of today's presentation did not incorporate this, and maybe in one of the webinar series, when you're talking about the model itself and how we model the predictors, I think we can be able to share more details. But of the routine, social demographic and clinical factors that you can think about, both distal and proximate factors were assessed for the input in the model and were evaluated for inclusion. And I think one of the main predictors, I think, was previously missed appointment, but we also looked at other clinical factors like even optimized drug regimens and things like that, viral load, linkage to care and things like those. I hope that at a high level answers that question.
Yes, Doc, I guess it does. Thank you very much for that response. Any other question or comment on the same? Okay, I cannot see any further questions, neither can I see any more hands. So I believe we are good up to that point. So I think if you would like to maybe access this recording, maybe later, or if you'd like to share it with any of your facility, feel free to access the recording from YouTube. We have posted on all the recordings from this virtual series on YouTube, and we are also going to upload this one as well. So feel free to visit our YouTube page and get the recording. Yeah, so up to this point, I think we are good. So I just want to maybe give a chance to few people to just make some remarks, even as we are approaching the closure for this training. So I think we could just begin from internal from our team. I'll just request Dana to maybe make a comment, final comment, as well as Dr. Mudoka. Then Faith, if you're available, you'll make the final remarks as we close. Then I think we'll request Ogutu Kennedy to lead us in a word of prayer as we close. So thank you. So I'll start with Diana, then Dr. Mutoka. Thank you.
Thanks, Otieno. I'll be very brief. Thanks everyone for your participation and your interest in today's training. Just a quick announcement. As some of us may be aware, we've been having this series of trainings. So we have a training on Thursday this week, and the focus of that training would be on ushauri, how we leverage the use of ushauri for NOPI verification in facilities that don't have EMR. So for all facilities that have not yet started NOPI verification and they are using and they are non-EMR, so we have a solution for that. Ushauri would support NOPI verification for those facilities. So we have planned the training on Thursday to focus on that. So kindly plan to attend and also extend the invitation also to the other team members. It would be great also to have the facility representatives from those facilities so that they can also benefit from that. So it would be very important that we be available for that session so that we can start immediately. We are made to understand that there are facilities that are non-EMR that have not started NOPI verification. So kindly attend so that we can see how we can do the work plans for such facilities as well. Over to you, Tim.
Thank you. Thank you very much, Diana, for that and for making the announcement for Thursday. Dr. Butoka?
Thank you, Bernard and Diana, for those sentiments. Thank you, everyone, for attending the session today. I was happy with the attendance and the questions asked. My plea is please utilize these features that is at your disposal. And if you have any feedback on ways that they are either working for you or areas that we can be able to improve on, please be gracious enough to share so that we can see where to improve. With increased documentation, as I said, machine learning relies on big data and more complete data. So the more you document, the more you're able to improve precision for programming. And that way we can be able to improve the health outcomes of the patients that we serve. Thank you, everyone, and look forward to the implementation.
Thank you very much for that, Dr. Mutoka. Yeah, so I think at this point, I want to just give it to Faith from NASCOP. If you could just make the final remarks as we close. Faith, I'm trying to look for you so that I can give you the mic. Could you just maybe raise up your hand? Okay, you have the mic.
Yeah, Otieno, you can hear me?
Yes, yes.
Yes, so first and foremost is to appreciate the data use team because what we've been presenting today is around data use. So I really want to appreciate the team that is leading this. And I think we are learning a lot, and I appreciate the amount of data that we have and what it can be able to tell us. And from the two presentations or the two key highlights that were given, HTS and IIT, I think there's already info that if we use machine learning, we could be looking at our program practices differently, and to some extent it would also give us some savings on cost, especially around the test kits, because we see if a client is at a low risk, then we do not have to take our time and also our resources to do the testing. And also for interruption into treatment, I think it would also be another area to be keen on, and to ensure that we curb that before it happens and improve our outcomes for our clients. So I think we need to optimize the use of the data that we have been able to collect, and be able to utilize it more. And so my request to the team is, I know machine learning is not a one-off thing. We will appreciate more of these sessions so that we can get familiar with the data and what it is telling us, and hopefully we shall be able to support this. And as Diana has said, kindly let's have more people join the sessions so that we can all be able to open our minds and our eyes wider on how to utilize the data that you have already been able to capture. Otherwise, I appreciate all of you for your time, and the team that has presented, lots of appreciation for preparation, and we really say a big thank you, and I wish you all a lovely evening. Thank you, and back to you, Otieno.
Thank you very much, Faith, for the remarks. We also appreciate your support and your presence throughout the training. So up to that point, I think before I give it to Kennedy Ogutu to just end it without a word of prayer, just to remind you, we have another session on Thursday, as has been announced by Dana, where we are going to look at the Ushauri use case for the NUPI verification. So again, let's turn out in large numbers on Thursday so that we can get sensitization and training on the same. Otherwise, thank you for your time and for being with us till the end of this session. We hope to see you again on Thursday. So at this point, I want to give it to Gutu to close it with a word of prayer. Karibu, Gutu.
Okay, let's pray. Heavenly Father, we thank you for the session that we've had this afternoon. I believe everyone has been enlightened, and the things that we have discussed, we've learned in this session, be put into use after today's session as we depart to our various places of rest. We ask you to be with us. In Jesus' name, I pray and believe. Amen.
Amen. Thank you, everyone. Have a great evening. See you on Thursday.